We have a quorum. Good evening, everyone. Today is Wednesday, June 27th, 2018. It is 5:30. I would like to call the order of the meeting of the Central Health Board of Managers, and I want to thank everyone for coming. And again, I know you guys are busy people. Thank you. All right. We're going to start off with citizens communications. Are there anyone signed in? Barbara first.
Dr. Zamora, I'm Ted Burton, Vice President of Communications. We have two people signed up for Citizens Communication. Both have done this before and are familiar with the process and guidelines, and they've also been given a copy of our process and guidelines.
Thank you, Ms. Burton. I first call Barbara Scott, Colony Park, CPNA, Neighborhood Association. Ms. Scott. Thank you for coming, Ms. Scott.
Good afternoon to everyone. I'm the president of the Colony Park Neighborhood Association, and I am here mainly, I did a letter, so I'm just going to read it to you. And it says, "Dear board members, the Colony Park Neighborhood Association would like to express its sincere thanks to you, the board members, and other Central Health partners for demonstrating a genuine interest in addressing the health disparities that exist in the Colony Park Lakeside communities. We greatly appreciate your efforts to connect to our community through community engagement. This has truly been a team effort led by Ms. Liliana Ordonez. Through Liliana's collaborative skills and her strive for perfection, we have begun to see light at the end of a very long tunnel. Realizing that several City of Austin and Travis County departments, along with community members, needed to be a part of this process, Liliana formed a Colony Park Advisory Committee. Even in its infancy, it has become an invaluable tool. We also would like to thank Liliana's supervisor, Yvonne Davila, for having vision and seeing the potential in this project, and recognizing that Liliana was and is the only person who could have accomplished bringing this team of partners together. Like other communities, Colony Park Lakeside have been waiting many years for additional health care services, and we look forward to our partnership with Central Health and their partners to the development of the Northeast Health and Wellness Center. We thank you very, very much. This is one of the few times that our community has truly been engaged, and we've been asked not what we wanted, but what we needed. And Liliana has done that. And with help from Central Health and supervisors, she's been able to accomplish what only one other person has done in that area. And we thank you.
Thank you, Ms. Scott.
Thank you.
Donald?
I'm here just to give you all an update and welcome Nicole Aquino to our team. I think many of you know Nicole as a Travis County attorney, but she has come from the dark side, and joined us in the light here at Central Health, and she has taken on kind of a hybrid role. She has a special counsel title to both you all, the board, as well as to the Office of the CEO, doing some of our women's health work, helping with a lot of contracts. She is not going to be the attorney, so Holly and her team will still be very much involved in everything we do. Nicole also has a distinct privilege of helping Monica and others with our public information requests, and we'll be handling a lot of the open records requests as well. So just welcome Nicole to Central Health. Thank you.
Welcome. Thank you, Nicole.
Thank you, Nicole. Thank you for joining the team. You were already a part of the team.
Again.
You're a part of the team. All right. With that, I don't see any other citizens. Stephanie? That's it? All right. All right, we're going to take the agendas as follow. The first will be number 1, and then we're going to do number 3. Number 2 will be number 3, agenda item number 3. Number 3 will be agenda item 4. Number 4 will be agenda item 7. Number 5 will be agenda item 6. Second, next one will be 6, will be agenda item 4. Sorry, okay.
Could you repeat that again?
Also, just remind me. If there's no objection, the agenda will be in the following order. Item 1, 3, 4, 7, 6, consent agenda, and then 2, 5, 6, and 9. And item 8 will not be discussed. And it is receive and discuss. No, that's not it. All right. Agenda item 8 is discuss and take appropriate action on Central Health owned property, including the downtown campus and adjacent properties. We will not take that. All right. We ready? Candy, you have questions? You're looking at me perplexed.
I got it.
Candy, you're looking at me perplexed. Did I miss something?
As usual.
You're okay with that?
I'll do all of it, but that's no problem.
You may repeat that?
If you would be so kind, I'd
All right. If there is no objection, the agenda will be taken in the following order. Item 1, 3, 4, 7, 6, and then the consent agenda, and then items 2, 5, 6, and 9. And item 8 will not be discussed, and it is, again, discuss and take appropriate action on Central Health owned property, including the downtown campus and adjacent properties. Over that. Number 1, agenda item 1, receive and discuss a presentation on the proposed fiscal year 2019 budget for the Community Care Collaborative. John and Sarah Cook and Mark Hernandez. Thank you all for coming. Morgan,
Thank you, sir. All right.
the floor is yours.
Good evening. I'm John Morgan. I'm the Interim Executive Director and the Chief Operations Officer for the Community Care Collaborative. I'm joined tonight by our Executive Vice President and Chief Medical Officer, Dr. Mark Hernandez, and Sarah Cook, who is our Senior Director for Strategy, Communications, and Population Health. Tonight we're here to talk to you initially about our proposed FY19 budget priorities. This should be everyone's favorite budget presentation. It has 0 numbers in it, other than the date, I suppose. So we really wanted to keep the presentation tonight at the strategic level and get some feedback from you all to make sure we're on the right track in terms of our priorities and the work of the CCC going into the new fiscal year. In preparing our budget, we've done a lot of work to ensure that the CCC work and our budget priorities align and directly support the objectives of the Central Health Strategic Plan. Most of our work naturally aligns to the first 2 strategic objectives as we're putting new services into place and we're aligning and improving different parts of the delivery system. We're really helping to execute on that healthcare delivery strategy that's based on the needs of our patients and where they come from, where they live. We're also really focused on a patient-focused healthcare system and really looking at the clinical quality outcomes, the quality of life, and the experience of our patients. We also contribute to the 3rd strategic objective in terms of our work in the DSRIP program that helps to fund a lot of the work that happens in our healthcare delivery system, as well as through our value-based payment and performance-based contracts that we implement through the CCC. Enhancement in key areas, this is really about asking the question of what are our priorities and what do we need this budget to do for us. There are 3 main things. We need to continue building our system infrastructure in the CCC. We need to continue our focus that we've had for many years on improvements to specialty care in the system. And then we need to continue building out the continuum of care. From a system infrastructure standpoint, we're talking about data collection and data connectivity. We're talking about our claims management system where we pay our providers for the services that they deliver to our patients. We're talking about technological solutions that really help us to build scalable and affordable, bless you, scalable and affordable solutions to some of our biggest problems. Specialty care is a combination of things. Again, the technology solutions that we'll leverage to really deal with some of these large problems that we have in our system related to specialty care access and getting to high quality outcomes in different specialties. It's also a joint planning exercise for us with the Dell Medical School, with Seton Healthcare Family, with community care, and it's also building on the relationships that we have in the community with other provider practices where we can make that happen. People like our partners over at Project Access, making sure that we're working with folks like that. The continuum of care is really about filling gaps for us. We know that there are gaps in the system, and we know that our system falls short in many ways. So this is about putting services into place that just don't exist and helping to fill those gaps and make sure that our patients have access to the most appropriate services that they need. In the past, you've seen us put together new service lines like urgent care, hospice, skilled nursing facilities. Going into FY19, Sarah will expand on this, but we're really trying to put solutions in place that focus on our patients' needs and when and where our patients need them. So some of our new initiatives will be in home care, in lower acuity respite care, things that don't exist today like that, home-based palliative care that help our patients with chronic conditions live their daily lives better able to control their pain. Sarah's going to go into more related to our work in FY18 so far this year and some of our strategic priorities going into next year. I'll just hit a few of our budget development assumptions that we'll go into in a lot more detail at Budget and Finance in July. Essentially, our budget will look flat. There's not a lot from a total sources and uses perspective that changes going into next year. We are realigning some of our resources to really fit with these different priority areas that we're talking about and make sure that we're using the resources, the limited resources that are available to us in the best way possible. You'll also see that the DSRIP program and changes in the DSRIP program have had an effect on our budget. It's really just a timing issue that as the DSRIP program changed from being in alignment with our fiscal year to now being based on a calendar year, we have a lot of expenses that were originally anticipated for this fiscal year that will now be in the following year and then in the subsequent year after that. And I think that's it, unless, Mark, you want to add anything to that before Sarah takes over.
So if John just laid out in broad brushstrokes for the three areas that we're thinking of focusing, I want to take some time and tell you a little bit about both what we've achieved in this year and how we anticipate continuing our success in those areas. Now, John did talk about Central Health's three strategic objective broad areas, but I wanted to lay out our successes in FY18 and our plans in FY19 according to the CCC strategic plan. And this really implicitly supports everything that Central Health wants to do through its strategic work and its priorities. And as a reminder, the Central Health Board approved this strategic plan last spring, I believe. So we have 4 strategic focus areas in our plan. And our first one is build an integrated delivery system, which may remind you well of one of Central Health's strategic objectives. We've done a lot of work in this area in FY18 so far. The Jonestown primary care site, which we just brought forward, we anticipate it opening in Q4 of this year. And the projected annual patients served for that site is about 3,000 once it's up and running. And I saw Jason Fournier walk in. In addition to that, we know that we have all those other sites that are being talked about in eastern Travis County that community care is participating in. We're supporting those planning efforts as well. We have our medication-assisted treatment program. This is a really exciting, best of its kind program to treat opioid substance use disorders. We have almost 40 MAP patients enrolled in that program already. It's a collaboration between integral care and community care and provides psychosocial supports along with opioid replacement therapy, really, that is proving to be very popular as it ramps up, and we're very excited about that success. And we have, as John indicated, the palliative care program that we're just launching, which is really important and is being emphasized in health systems across the country. I think you'll hear about palliative care. It's distinct from hospice care, but it helps people live with a debilitating illness, even if that illness isn't terminal. But it's a really important step in our health system to ensure that patients get the treatment, the pain management, and the comfort that they need. Keep them out of the doctor's office, the emergency department, right, the inpatient wards, and keeps them healthy and happy in their homes. So we've just launched that. In FY19, build that integrated delivery system. We're going to work with community care to support those, though we expect that services won't ramp up in Eastern Travis County until really FY20. So we're anticipating that. We know that we need to keep everybody connected, that technological and data connectivity will be supported by our next organized healthcare agreement, which we hope will better provide hospital data to our community clinic partners. And then we have those home health and medical management services. I want to take a quick second to talk to you a little bit about medical management. And we plan in FY19 to strengthen the program. We've done an initial round of results for the 300 persons who have received medical management services. And we've found with statistically significant results that following a period of medical management, we see inpatient use and emergency department use decline for those patients who are involved. And we see primary care use increase. So it seems to us that based on this first initial analysis, we're getting some of the results that we would hope for. And so we know that as we build out that program, we can continue to support and strengthen that team, which is comprised of nurses, social workers, community health workers who really support those patients who need the most care. In our second strategic focus area, redesigning coverage programs, as you know, we have designed and received approval for our sliding fee scale enrollment program. We've talked about that. And next year is really going to be devoted to implementing that. That's an exciting program to get those people into a managed program with some defined benefits, including pharmacy, which will be very important for this patient population. And we're excited about getting that underway in FY19, and a lot of pre-planning is taking place on that already. And we're also going to continue the conversation about 12-month enrollment in our coverage programs. So that's coming in that strategic focus area in FY19. For our improved value and care model, which again supports that financial sustainability pillar in Central Health's work. You've heard about our hub and spoke specialty care model. This is to train primary care physicians to be great givers of rheumatological care within the primary care setting, trained by a rheumatologist who's going to be devoting time to these physicians and helping our patients get faster and more convenient access to those specialties and skilled providers in those areas. We've launched our ENT project, as you know, at Austin Regional Clinic. For ophthalmology improvements, this is something that we've been working on for a number of years, and I want to let you know that I just received data today that shows that in FY18, we are on track to double the number of people that we served in FY16. So we have really expanded our capacity. And we've done that in smart ways by working with new ambulatory surgery centers to provide important, surgeries and cataract treatments. We've expanded our network of providers, and we feel that we've really provided value and a really large increase in service to our community in ophthalmology. And then finally, on alternative visits, this is something that we launched, I believe, in FY17. But right now, the CCC is supporting about 5,000 nurse visits a month. And in the first 2 quarters of FY18, we will have supported 4,000 clinical pharmacy visits. So we are helping our primary care teams expand beyond the simple, physician relationship and understand that there are so many talented professionals, healthcare professionals out there, and we want to support their work. So in addition to the nurses and the clinical pharmacists, we're supporting visits with nutritionists and also with community health workers. We're pleased with how that's going. Again, in next year, we'll continue all of those services that are on the left-hand column and increase our forays into technology-assisted care. Telemedicine was big in the last session, and we're starting to see that pick up here on the ground. I think we have an exciting opportunity to test some ideas around digital urgent care, continuing our e-consult work. Another sort of best-in-class program that we're looking forward to launching across our primary care providers is the fecal immunochemical testing, I believe, which is really an at-home initial test to look for markers that may indicate colon cancer. The exciting part about this FIT testing program is it was really imported here as an idea that could be launched in FQs by Dr. Michael Pignone, who is the chair of internal medicine at the medical school. And I think at Dr. Pignone's urging, the community said, you know, that's something we can do. And he is testing it at community care currently. And we believe that it is an initiative that should be rolled out to all of our primary care partners to allow for early screening and detection for colorectal cancer. So we're very excited about that and look forward to building that in and reimbursing our providers for running those programs next year.
And if I can jump in real quick, the only thing else I would add with that, with the advent of this test and the availability of this test to our broader population, it allows us to repurpose some dollars that we had been spending in doing screening colonoscopy back to general gastroenterology, where we continue to have a need for more GI services in a general sense. And this allows us to better move those dollars into that space and help push down wait times and access to the gastroenterologist in areas other than colon cancer screening. So,
which is a perfect segue to the next phrase, which is about new initiatives in neurology, GI, podiatry, and so we are really embarking on rigorous joint planning with the medical school, again, and that infusion of brain power there to think about ways that we can address these important services in our community. So we'll keep planning on that, and you'll see that reflected in the budget, again, at Budget and Finance. And finally, just to touch on our fourth strategic focus area, you know, focus areas 1 through 3 are important, but what's really important is optimizing the health of our covered population and making sure that we are keeping an eye on how our covered population is doing. We've started to look at social determinants of health interventions as a way to improve our covered population's health, and we have provided 2,262 rides in the first 6 months of our transportation pilot. So we know that that's an important step in getting people into the care that they need, into the services that they need. We are working to launch a short-term pilot with Meals on Wheels to support the nutrition needs of fragile MAP patients who have been discharged from the inpatient or the skilled nursing facility. So you can expect to hear more about that. We've really made ourselves be present at community conversations around healthcare for the homeless, I think, in a different way. We're partnering with the city on a number of initiatives. We co-sponsored those pop-up resource clinics with the city and with EMS. We're participating in a blockchain program with the city of Austin to ensure that homeless patients can access their identification as needed. And we're joining in other citywide efforts, including conversations around the Pay for Success pilot. We know, and Mark speaks very eloquently about this, that the health outcomes for persons experiencing homelessness are not as good as they could be and not as good as they should be. And so as we work to optimize the health of our covered population, we know that that's an area where there's great disparities and where we can do work. So we've started in this year to become a part of that conversation much more fully than I think we have before. Lots of conversations with Austin Public Health. And of course, there's always DSRIP. And in this next version of DSRIP, or in the latest version of DSRIP, the state and the federal government have really doubled down on clinical indicator improvement. And so we're doing all of this activity in related areas, but DSRIP really says, how is the health of your diabetics improving, for example? So any activity that you hear about around this new DSRIP program is really related to improving the clinical outcomes of the patients that we serve. And so, as we look to what we'll be doing in this focus area in FY19, continuing the DSRIP program is part of that. And we believe that that will really support the improved health of that population. We have also decided that this is the year to launch an internal process to start looking at what our health disparities and health equities are within the covered population. So this is a standard, let's say, again, another national model around a health equities roadmap. And we're going to start digging down into our data, understanding the health of our population and where there are places for us to improve and target some interventions in the coming years. And I think that you would see activity in that, not in FY19. We really are committing to starting to look closely at our data in FY19 to make those improvements. And so back to John, if that's sort of the more detailed picture of what we hope to achieve in the budget, he'll talk you through when you'll be able to see that.
We're certainly happy to take questions and get any feedback from you all about any of the work that's being proposed. This is certainly not all of the work. There's a lot of things that go on in the CCC. We thought these were the most important things to highlight in terms of priorities going into next year. We have several different venues that will have continued discussion on the budget. I think you all are pretty familiar with this process and timeline. There are a few additional bullet points on here for our discussions with the CCC board, starting July 10th, where we'll present this budget for the first time with the CCC board of directors. As I mentioned earlier, we'll be back at July's Budget and Finance Committee with the numbers and the details that goes behind all of these initiatives and all this work. So we'll be back, but we're happy to take any questions that you have now or take any feedback, guidance.
Mr. Morgan, Dr. Hernandez, Ms. Cook, Dr. Fournier, thank you. You're incredible. You guys are doing fantastic work. I mean, I'm so proud to call you guys my friends. Board, any questions? Ron? Oh, I'm sorry. Sherry.
Mine are very, very fast. Being the data nerd that I am, I would love to see the results that you said were statistically significant on the medical management data. On the 12 months enrollment, I just hope we can move to that. Mm-hmm. On the blockchain, I would like to discuss that further with you. I'm aware of the project, and it's certainly a big issue for our homeless who don't have identity or a way to keep up with their records. I'd like to also discuss the blockchain with you, get an update on the Ride Austin, and also discuss with you the health equities roadmap, as these are going to relate to our to things that we have going on in our strategic planning committee here. So I'll take it offline. Let's just arrange a meeting if that works for you. Thank you.
Thank you, Vice Chair. Ron?
No, you raise your hand first.
Well, thank you all. You know how much I really appreciate all the work that you are doing. I have a few questions. One is more of a strategic question, really, that it's just been mind-boggling. Who is managing Travis County's, like the underserved patients in Travis County overall? Because I know what the question is, I know that our patients are being seen at other facilities all across, at Peoples, at Boynes, at all these other different clinics and hospital systems. So who is collecting the overall data to manage their overall health? So is it CCC? Is it someone else? Because I know that most of the data that you are working with is Community Care, CN, and I'm not sure if UT as well. So if you can help me navigate that.
So I'll offer a few comments and I'll ask my colleagues to add color commentary as necessary. The CCC is the responsible entity for what we deem, or what we'll often refer to as the CCC population. That CCC population is basically broken into two groups. MAP, so anybody who is on MAP, without a doubt, they're part of the CCC population. The other group would be patients whom do not qualify for MAP, but by virtue of their FPL level, typically we're talking at 200% or less, receive a subsidy of their care via the CCC. That is almost always through the negotiated rate that we pay primary care providers for caring for those patients on an encounter rate basis. Then there is another group that we would consider to be ours because it lives inside of the kind of system definition, and that is those patients for whom Seton cares for, that live in that definition of being under 200%, receive services from Seton, and would be ours from a sliding fee scale standpoint if they ever showed up in one of our outpatient facilities. But there is a population of patients there that would qualify for sliding fee scale services or might even qualify for MAP. They don't sign up and they don't touch us in the outpatient setting, but they come into the hospital. We know about those people as well. Their data is reported to us as well, and we consider that part of our population. When you look at that number in aggregate, the number is around 96,000, 97,000 people over the course of a year. That's the population that we hold ourselves responsible for caring for, and thus we aggregate data on that population that I've just described. So for that population, the entity you're asking about is us. We're responsible for that group. Are there people who clearly have need but wouldn't live inside of those definitions I just described, and who's collecting their data? I don't know who's collecting it. UT at some point wants to collect healthcare data on all people in their catchment and is working towards building that sort of data infrastructure. So at some point, maybe they'll have a bigger, broader data infrastructure that would hold all of our population and others. But for today, the population is how I've described it, and we're the entity who I believe, I mean, I come to work every day believing we are the responsible entity for that population, both clinically and fiscally. So I wouldn't push it to anybody else. I think it's us.
No, so it's just been always just thinking of a scope is when we're talking about Travis County and who are, and I just don't want us as a board to think about there are certain pockets that we're missing and how can we intervene. Like you're doing incredible work in your population, and I see as overall as a board we have a responsibility in addition to the other folks who are under our umbrella.
And so to your point, one of the things I would say is if there's a missing population in what I just described, it's that piece that sees the hospital but doesn't see the rest of the system.
That's it.
And next year, a little tidbit, we're asking, not in our budget, but we're actually asking through Enrollment and Eligibility's budget, Kit Abney Spells that runs that department, for a enrollment eligibility person who will live inside the hospital. Because we need to catch those people when you have them captive, they're there in the hospital. We know they're not part of our system because we can't find them in our system. We need to not let them leave the hospital before they've become part of our system. We have a transition of care nurse there now, and we identify those people all the time. We need to streamline the enrollment process to get those people connected to the system so there is somewhere for them to go when they leave the hospital. And those connections get made before the patient gets out of our hands. If you let them get discharged, your chances of being able to create the appropriate follow-up just drop off precipitously. So
I'll give us some food for thought to think about how we can catch those patients. My second question, actually it's more of a comment about the colorectal screening that you have. It's just a wonderful program, and I'm a big advocate for prevention, and something about Dr. Pignot's project, I believe, also has a component of health literacy in empowering and educating patients, which is very, I think, novel in a way here in our community, especially with our underserved population, that we are empowering them and educating them, not just giving them these screenings. And that's something we have to give credit to you and to the med school for bringing that perspective and treating our patients as anyone else, not just because they're underserved, that we are treating them with dignity and respect. The third one, my last, I'm sorry.
sorry.
So in talking about health disparities, I know that Sherry has some thought, and knowing that some of the data already exists, so I'm just wondering, out of curiosity, what are you going to be working with other stakeholders? Are you going to be collecting? Or are you going to be building up that infrastructure with our disparities?
I'll make a quick comment, and then Sarah may or may not want to jump in on the back of it. One of the first things we have to do as we create this kind of health equities roadmap, and really by that roadmap, we're really talking about a process map, right? So this is the process by which we will get to a state where we can both identify and address health inequities when we see them. That's the goal of that project. One of the first things we have to do is do a very robust look at what data do we currently collect. And, you know, we were having a conversation around care for individuals who are gay, transgender, LGBT. It goes on, there's some other, but that population, and we realize that as an overall system, we don't collect that data well, if at all. And so if we were trying to ascertain whether, as a group of individuals, there are health inequities that exist for that group of people, we wouldn't be able to easily ascertain that from our data because we don't actually collect that data. And that is historical. It's also wrong. But you also have to figure out and inculcate in the culture of healthcare the sensitive ways to gather that information. And so one of the things at beginning is just figure out what our data needs are. What can we speak about today in terms of inequity? And we can begin to then immediately dive into where the inequities around those things that we already know. For those things that we realize we don't know, the first thing is build the data system so that we could know, which means we may have to begin to collect data and ask people questions that we haven't previously been asking, because that's the only way you're able to create the appropriate amount of knowledge. It's those kinds of things that live on that health equities roadmap, but it starts with what do you know, and it ends with I've identified in a subpopulation a health inequity that exists for some population, and this is how we go about devising interventions that hopefully will relieve the inequity, at least as much as healthcare delivery can do that. You know, I offer up the problems are bigger than just what healthcare delivery does, but we contribute to it, and so we need to make sure that our part of it is fixed. Sarah, I don't know if you have anything to add to that.
And I think we do bounce our data off of the city, the county, regional, local, and national indicators, so that we'll understand, hey, we're not performing well, but maybe, in working this out strategically, we think, do we address those where the gap between national and local performance is the greatest? So I think that we do use the other data sources, but what we're really asking ourselves to do in this process is to dig into the clinical indicators that we know that we have clinical data that doesn't get captured in some of those maybe awesome public health critical indicators.
And what's the status under eConsult? Where are you in the process?
Let me speak to that. So the board approved several months ago that we would enter into a contract with a vendor for a referral management and eConsult platform. Just recently, we had to discontinue our discussions with that particular vendor, and we're having to reboot our conversations around what the solution is going to be. Fortunately, in our contracting and due diligence work, we came to the conclusion that that wasn't the vendor that we were best suited to work with, and that piece of infrastructure is incredibly important to us. We have to absolutely get it right. So we're having to, and no, fair question. So we are in the process right now of doing another search for vendors right now, and we'll have more updates for you coming on that in the near future, over the next few months.
Thank you. Oh, thank you.
Okay.
Well, thank you, Sherry, for bringing up the disparities issue, because that's something that's been near and dear to my heart, and I've been advocating for. I wish we had participated in the disparity study. I want to say that again, but Central Health chose not to. Either way, if there's a back way, a back-ended way that you can get into it, which I'm sure there is, we support you 100%, but I also am very interested in being involved in that process and in that conversation. With respect to the palliative care, are you looking at a system? What would that look like? What is that looking like right now?
Yeah, and so what we've done is we've gone into a relationship with a practice that is providing home-based palliative care services to those patients who we identify are appropriate for the service. Those are individuals who basically, as Sarah alluded to, have a chronic illness that causes them to be debilitated, usually because of pain, but it could be because of other symptoms like shortness of breath, or, there are other sorts of symptoms that debilitate you. And in general, those individuals engage the healthcare system frequently at the emergency room level in an attempt to get some relief from their symptoms. It's a big pain to get on a bus or have to call an ambulance every time you're short of breath. We ought to have a better system that comes with it. And so we specifically contracted with this group because of their interest in providing home-based services. We didn't want patients to have to get out of their homes, because these patients obviously are debilitated, and asking them to leave their homes is not a great plan. From a system perspective, that is a piece. So we need to begin to connect that piece to hospice and palliative services as they exist in the hospital, hospice and palliative services as they exist in specific outpatient practices. So it's well established in oncology practices, not so well established in pulmonary practices for patients with lung disease, chronic lung disease, cardiology practices for patients with chronic heart failure that is severe, gastroenterology practices with people who have chronic liver disease that is severe. Those individuals tend not to have connections through their primary care or their specialty care practices. So now it's a matter of connecting all of these pieces. So we need a system. The question is a great one. We need a system of care here, not a one-off solution. The problem is as we looked at this, what we realized is we don't have enough of the pieces to make up the system. So we've got to bring some of the system pieces in, and then our job becomes, okay, now how do I connect the piece we just obtained to the pieces that already exist, and what is the next gap we need to fill? So at some point, you get enough of the gaps filled and you create enough connections, a system emerges. And I think that's how we'll approach that whole notion, Cynthia. So it's part of a long-term strategy to develop a system of care in that space.
So you'll be sure to include the neurological debilitating.
Yeah, so I mean, patients who have MS, patients
Right.
who have chronic seizure disorders, these
Right.
are people who could benefit from these sorts of services. So we have to kind of look at it service line by service line and say, who are the most commonly afflicted individuals who could benefit from this sort of service, and how do we make sure they get connected? Earned.
Thank you very much, but I'd like to talk to you about that also. And with respect to, again, the 12-month enrollment, I thought we had approved that, not this past year, but the year before, and that we were going to be moving towards that in January of this year or last year, from moving from the 6-month to the 12-month.
Approved yet. We've been working towards that goal. We did approve the program to enroll our current sliding fee scale enrollees into a program that'll start either in October or January. We're working out the timing of that enrollment to begin.
I thought we had approved that for MAP. I remember us having this discussion. Maybe that's something we need to go back and look at.
Yes, and that will actually come up in another agenda item in this meeting.
Okay.
I can address that.
Yeah, because that is something that I thought we had already approved, and we're proud. I think that what we didn't get was the cost that it would be for us.
Correct.
And that was something that you were going to look at, and you were going to come back to us, but that's what we were looking at. And
Those conversations are continuing, so there will be more to come on that.
And we'll be discussing it.
Yeah, as you see, we're going to bring this back to budget and finance and to strategic planning, and so this is just an informational item, folks. So if we can,
Thank
we're
you.
a little behind schedule,
Thank
so
you.
I'd like to.
well, if you can, maybe we should all be limited in how long we speak. Thank you.
I heard that. We got to move on.
Well, you have this
All
side
right.
of the table too.
Okay.
That's
all
right.
Just have
All right.
just a quick comment.
All right.
And relates to your comments about your population served. I heard 3 general populations. And as a board member, it sort of concerns me that we're not able to say who those we'll say who they are, but we'll not say, we said we might have some that we don't know about or not covered or not able to identify.
So
So I just want to make sure.
real
I'm
quick
clear on
response to that is MAP is a program in which people enroll prospectively. So we always know who those people are, and we can longitudinally follow them, all of that stuff. Sliding fee scale patients, by the very nature of the program, these patients are actually patients of the clinics that have a sliding fee scale program. We don't know who they are until we receive their information from the clinic that a new patient has walked in, has become a sliding fee scale patient for them, and now they're sending us a claim so that we can pay the encounter rate. So there's no way to, and that population may change year to year. And then the population that hits the hospital is exactly the same. Until they hit the hospital, we don't know who they are and don't have a relationship with them. That is why we wanted to go to this MAP expansion, or whatever we're calling it, the kind of expansion of benefits to the sliding fee scale population. because through that, we register these people and then we know about them. And we, the CCC, then have a relationship with them. We have extended this benefit to them, which allows us to directly interact with them, as opposed to being a one-off, arm's length relationship because the clinic intervenes. So I hope that provides a little clarity.
It'll make the administration of the sliding fee, if I may, I'm sorry.
You may.
The sliding fee scale program look a lot like what you're doing for the MAP population.
Right.
But is there an unfunded liability that is created by this population that is constantly serving that we need to be mindful of?
I think we always have these gaps. We've got two main types of gaps. We have people that are eligible for one of our programs but are not enrolled. So we don't get any data on them. And then there are people that are enrolled in the program but receive services outside of our network. So if we're not the payer for those services, then we don't receive any information on them. We think of that 100,000 that we serve on an annual basis. That's about half of the people that qualify for services in Travis County on an annual basis.
I follow you. I just think that that's information we need to let the taxpayer be aware of. And perhaps you have, but I think it's a risk that could come.
And we'll hear this again. Julie?
I'm sorry?
Is that Shannon? We had any questions? Do you have any more questions, Shannon?
No, I was just making a comment about that.
Okay, and no questions. Julie?
So I think I heard you mention one thing about maybe participating in ECHO. So would y'all include some expense for that in your budget? Because that's something we agreed to as a board in our budget. And I think there are a lot of questions that are unanswered about that program.
We haven't made any decisions about that at this point. The CCC is at the table in those conversations. Any action that we take to participate would have to come back to the Central Health Board for approval. But we are participating in that planning discussion.
And part of the participation in that planning discussion is to get those questions answered.
Yeah, I think there are a lot of questions I have that are answered. And I thank you, Dr. Hernandez, for speaking so openly about this and the need for housing the homeless, because that is an urgent need that we have. I'm not sure that this project in particular is the way that we need to go about it.
What I would say is it creates another opportunity for conversation and due diligence, because if we decide at the CCC level to participate in this, and we're doing that in very close conjunction with Central Health, who's also working through that process, we will yet again be in front of us for the first time to have the exact same conversation that you guys have had, and so there'll be another opportunity for further inquiry and conversation on your parts, as we would need your approval to be able to pursue that.
And the board will have full view of those terms.
Yep.
Part of us is making sure that we get the answers to the questions that you guys have asked around Central Health's participation, because us and you guys would look identical inside of this.
Yeah, I think there are just a lot of holes in this about the financing of it, who ends up with the property at the end of the program, what happens to the homeless after the program is over. So, just want to air my concerns.
Okay. Anyone else? All right. Again, this is an informational item. No action is needed.
Thank you.
We will hear again at Budget and Finance and Strategic and Planning. Thank you all for coming.
Thank you.
Sorry about that, Ms. Valdez. All right, the next one's going to be agenda item 3. We're going to actually take the next two together. Receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District, doing business as Central Health, and Mike Giesland, cause number D1GN 17005824, and it's 345th District Court of Travis County. And then we're also going to hear discuss and take appropriate action on the agreement between Central Health and a 2033 fund for the lease of real property located on the Central Health Downtown Campus, as recommended by the Central Health Downtown Campus Committee.
And go ahead and read 6 and 7 as well.
6 and 7 as well?
Yeah, because you're going to hear all 4 in executive session.
Okay, sorry. Okay. All right. 7 is discuss and take appropriate action on an update regarding Sendero Health Plans, Inc., including the effect of federal legislative and regulatory actions. And item 6 is discuss and take appropriate action on these 1115 Medicaid waiver delivery system reform incentive payment, DRISRIP projects, the Community Care Collaborative, including health care delivery arrangements and other interrelated community partnerships. All right. So, I need to read this first, don't I?
Yes.
Yeah. All right. It is 6:20, and I announce the board is convening an executive session to discuss agenda items 3 and 4 under sections 551.071 of the Texas Government Code, consultation with attorney. Item 4 under section 551.072 of the Texas Government Code, deliberation regarding real property. And items 6 and 7 under section 551.085 of the Governing Board, certain providers of healthcare services.
Under Texas Government Code.
Oh, sorry.
Skip the line.
Okay. Under the, of the Texas Government Code, deliberation of Governing Board of the central certain providers of healthcare services. All right, guys.
Just ask for clarification.
Technical issues.
Okay, we have audio. We need music. Okay. I was just keeping it up.
Okay, we're on.
Ready? It is 9:11, 9:11, and we're coming out of executive session. And the board will reconvene in open session. No action will be taken on items 3, 4, 7, or 6. Thank you. So now we're going to go to agenda item, consent agenda. C1, approve minutes for the following meetings of the Central Health Board of Management, May 21st, 2018, special meeting, and May 23rd, 2018. B. C2, receive a report of the May 2018 financial statements for Central Health as presented to the Budget and Finance Committee. C3, receive a report of the May 2018 financial statements for the Community Care Collaborative as presented to the Budget and Finance Committee. C4, receive the May 2018 investment report and ratify Central Health investments for 2018. C5, approve a contract between Central Health and Braun and Butler Construction for construction management services in an amount not to exceed $1,800,000 and authorize Central Health Board's president and CEO to negotiate and enter into a contract on terms similar to those presented on or on terms more favorable to Central Health as recommended by the Budget and Finance Committee. Do I hear a motion?
I'd like to move that we adopt the minutes.
Hard.
And
Second.
approve the consent items.
Okay.
Second.
Okay. So I have a motion by Board Member Valdez, seconded by Board Member Greenberg. All in favor say aye.
Aye.
All against say no. Anybody abstaining? All right. Thank you. Consent agenda item 2. Agenda item 2. Receive and discuss reports from board committees, Budget and Finance Committee, Strategic and Planning Committee, and the Downtown Campus Committee. Dr. Bell, Ms. Greenberg, and Ms. Daniels not here today.
I think we covered all of our issues that we discussed in Budget and Finance, including our consent agenda. So that's my report.
Ms. Greenberg?
I'm going to make mine very brief, except to say that I thank the members of Strategic Planning Committee. I thought we had a very productive meeting in a short amount of time. We talked about the strategic work plan proposed for fiscal years 2019 and 2020. We talked about priorities, what would be our top priorities, speaking of priorities. We talked about dashboards and partnerships. And we also discussed that we would continue the discussion on the strategic work plan to continue refining it and the outcomes, and that we also had a brief discussion, and this gets into I think the conversation we've had about not moving forward on initiatives unless we have consensus, and that is workforce, and that there needs to be a common consensus among strategic planning and then among the whole board as to what we mean when we say workforce. Conclude with there.
Okay. Board Member Matt Daniels is not here, so we won't hear a report today. No action is needed on that one.
Agenda 5.
Let's get to missing. Oh, sorry. There you go. All right. Agenda item 5, receive and discuss a report from the President and CEO on Central Health operations and current activities, including A, the current strategic plan and related measures or dashboards, B, an assessment of systems and processes and prioritization of activities and initiatives, and C, personal matters. Mr. Union.
Members, there's just a few items in your packet I think that are self-explanatory. I'm happy to answer any questions, and as alluded to earlier, we'll be bringing a final strategic work plan back, as well as other reporting items on service deliveries at the July and probably again in the August meeting too, so that way you can make your budget decisions with those documents all side by side. Thank you.
Good.
Yes, sir.
Yeah. Agenda item 6, discuss and take appropriate action on the 1115 Medicaid waiver. So 9. Confirm.
We had open, I'm sorry. We had a small open, I'm sorry. Go back to 6.
Right. Discuss and take appropriate action on the 1115 Medicaid waiver delivery system reform incentive payment projects Community Care Collaborative, including healthcare delivery arrangements and other interrelated community partnerships. Mr. Booth.
Yes. So members, I want to take this opportunity to address the work that we're doing surrounding the Rosewood Zaragoza building and programs too. As you know, there is a renovation that is upcoming for that facility in order to improve the clinic side of it. On the other side of the building through the walkway is a resource center, and that's a city property, but it's also a city-managed program and resource center. We recently had a community meeting at, and those board members that were able to make it, thank you for being there. The point of clarification of not only the community meeting, but the work around Rosewood Zaragoza is to make sure that everybody understands this is not a popularity contest. And even though we have web-based surveys, we're going to be doing in-person surveys of the people that live and will hopefully be utilizing these services, is not to count and tally votes. It's simply just to inform the decision. Ultimately, the decisions about the non-clinical services, and there's some criteria that I'll be posting on the message board to give you some insight into how we think about this at the management level early next week. But the whole point around these services that is, it's got to work for the clinical partners. It has to work for the patients that we're going to be serving. It has to not duplicate what the city or the county is already doing. Mm-hmm. And the final decisions around who provides those services, if there is a decision to be made by Central Health, it's going to happen here at this board. If there's a decision that's made with one of our providers, it's going to happen with that provider and their management structure. Or it may be the city's decision. I'm deferring to Shannon on this, but it's not as easy as just simply having a survey, tallying the votes and saying, this one is it. That is simply one piece of the decision-making puzzle. So I need to clarify that because there's at least one organization that I knew of that got out there with the survey and suggested that it might be a popularity vote, and there's anything that's couldn't be any further from the truth. But thank you for allowing me to clarify that.
Of course. Thank you, Mr. Eaglin. All right, agenda item 9, confirm the next regular board meeting date, time, and location. The next Central Health Board of Management meeting is scheduled for July 25th at 5:30 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. With that, do I hear a motion?
Second.
All in favor, say aye.
Aye.
Thank you, members. Thank you, members.
Thank you all.
Sorry, it was a long one.
Did you get that out fast enough, Sherry?